Then some drugs have very specific adverse effects or some specific points about them, which we will discuss. In cardiology, few drugs which are important are adenosine. Its T half is 6 to 10 seconds only. It acts via adenosine receptors that activate potassium channels used in the treatment of SVT. And side effects include anxiety, chest tightness, bronchospasm, and facial flushing. So, if the question mentions patient has a history of bronchial asthma or bronchospasm, then adenosine can have one of the side effects as bronchospasm. Then do check if that is mentioned in the question. Then ACE inhibitors, it reduces the mortality in heart failure and post MI patients, and it slows diabetic nephropathy. Contraindications are bilateral renal artery stenosis and severe renal impairment. If the GFR drops more than 25% or creatinine rises more than equal to 30%, then consider dose reduction or stopping the drug. So the question will mention creatinine or eGFR before starting the ACE inhibitor, and then it will give same values 2 weeks after starting ACE inhibitors, and then the question will ask like whether you should stop it or continue it or other options accordingly. So then you have to see if the drop is more than 25% of eGFR, then we have to consider reduction of the dose or stopping the drug. Therefore, we'll check after 2 weeks of starting the drug. Other side effects are dry cough, hypersensitivity, angioedema, and hyperkalemia. ARBs are also same in indications as ACE inhibitors, but cough is less common as compared to ACE inhibitors. So if the patient is not able to tolerate ACE inhibitors because of dry cough, then we can switch it to ARBs. But angioedema is still a side effect of ARB as well. Digoxin, although it is less used in India, but in UK NHS they are still using digoxin. So it delays AV conduction, slows ventricular rate in atrial fibrillation and flutter, effective in coexisting heart failure with atrial fibrillation. And it may accumulate in renal failure. It has a narrow therapeutic index, and in chronic use, it can cause gynecomastia. So, if a question mentions patient is on digoxin and patient has gynecomastia, then it should click that gynecomastia is one of the side effects of long-term use of digoxin. Toxicity, when digoxin toxicity occurs, patient presents with nausea, vomiting, diarrhea, bradycardia, heart blocks, hypotension, hyperkalemia. It can even cause VT, and long-term effects can cause yellow vision known as xanthopsia. Amiodarone may displace digoxin from its protein binding sites and cause digoxin toxicity. Digoxin therapy, patient will have a reverse tick sign. It is a sign of digoxin therapy and not digoxin toxicity. Hypokalemia, hypomagnesemia, hypercalcemia, these can precipitate digoxin toxicity. So we avoid hypokalemia, hypomagnesemia while patient is on digoxin. So you can see that hypokalemia can precipitate digoxin toxicity, whereas digoxin toxicity presents with hyperkalemia. This is to be remembered. Then HMG-CoA reductase inhibitors, they are statins, the rate limiting enzyme HMG-CoA, and they reduce LDL and increase HDL. It reduces mortality in ischemic heart disease, diabetes, hypertension, and other cardiovascular risk factors. Common side effect is drug-induced hepatitis and statin-induced myopathy, which can present with rhabdomyolysis, which is more likely in patients with renal impairment after high doses which are combined with fibrates. Nicorandil, which is anti-anginal, and it presents with transient headache, flushing, hypotension, and reflex tachycardia. Amiodarone is an important drug. It is used in indication is SVT, VT. and it causes QT prolongation. So it should be avoided if the question mentions patient has QT prolongation or ECG shows QT prolongation. Protein binding increases the effects of digoxin and warfarin. Side effects is arrhythmia. It can cause torsades de pointe because of QT prolongation. Ataxia and long-term use can cause pulmonary fibrosis, hepatitis, photosensitivity, and amiodarone can cause both hypothyroidism as well as hyperthyroidism. So it can cause hypothyroidism where you may need not stop amiodarone. If it is essential, you can continue amiodarone, but you can add levothyroxine supplementation if amiodarone induced hypothyroidism occurs. But if there is hyperthyroidism, there is amiodarone induced thyrotoxicosis type 1 and 2. In type 1, there is increased release of thyroxine hormone from the thyroid gland. So there is thyrotoxicosis, which can be managed with carbimazole, methimazole. But if it is type 2, which is destructive thyroiditis, which can be seen on ultrasound as small gland and reduced or absent uptake in radioactive iodine scans, then in that case, type 2, we need to start on corticosteroids and we need to stop amiodarone. When certain anti-anginal drugs, uh, you need not remember all the side effects, but very specific side effects which are particular to a particular group of drug you can remember, like calcium channel blockers, like amlodipine can cause ankle edema, and they also cause constipation. Verapamil is also commonly, it causes constipation. Beta blockers, bronchospasm, so it should be avoided in asthmatics, particularly the non-selective beta blockers. Then fatigue, cold peripheries, it should be avoided in peripheral arterial diseases, and it can also cause sleep disturbances. So in past medicine, there are few questions which mentions that patient has been recently started on a beta blocker, and now patient is having insomnia, sleep disturbances. So the answer for that is beta blocker. It will ask which of the drugs can cause these side effects. So answer is beta blocker. Nitrates, headache, postural hypotension, and tachycardia. Nicorandil, as discussed in the previous slide, it can cause headache flushing, but it can also cause anal ulcerations. So if the question mentions a list of drug and then patient develops anal ulceration after starting these 3-4 drugs, then they will ask which drug is responsible for anal ulceration, then it is Nicorandil.